Basically, total 80 patients were recruited and 41 in the NACRT group, out of which 4.2%. In 2 patients there was no tissue diagnosis and 4 had recurrent cholecystitis, so we could not start the chemotherapy. So per protocol there were 31 patients, out of which 2 again do the consent while on chemotherapy, and 3 it was delayed or deferred because of the different issues like recurrent cholecystitis, stent block, and 1 had an active pulmonary tuberculosis. So out of these total 25 completed, and out of which total we restaged and progressive disease total 8 and 14 underwent resection. On the other side 39, 4 had crossover, so 43 patients were there, and finally underwent section were 38, and out of which 2 had a non-malignant cause of the disease, so 36 had adenocarcinoma. So per protocol analysis, per protocol there were 80% patients who completed the intended neo-adjuvant chemotherapy in the NACRT group, dropout rate of around 19.35%. Recurrent cholecystitis due to stent block was the foremost reason for dropout. So these are the basically primary and secondary endpoints. So basically, obviously the days from randomization to surgery, the time period was unusually long. We expected that we will be able to complete the NACRT in approximately and restage patient in approximately 110 days. But the average time we had around 180 days, 170 days, and in the upfront surgery was 45 days. Resection rate was low in the NACRT group, that was 45% only, as compared to upfront surgery that was 87%, and the rest of the parameters were there was no significance. Okay, 3 months CA19 level we had a significant drop in the NACRT group. The other parameters, the secondary endpoints like RG resection, pathological lymph node involvement, the perineural invasion, lymphovascular invasion, all favored NACRT, but we could not reach any significance level because of the smaller sample size. Again, the post-operative complications like POPF were less in the NACRT group. Again, we could not reach the significance level. The median overall survival, the disease-free survival favored NACRT. So the main drawback of our study is that basically we had a higher dropout rate, and treatments were deferred, delayed due to recurrent plastic stent blockage and cholecystitis. On the average, patient were after the randomization, patient were with us for 170 days, which I said, and again sometimes it was for more also. So 170, you can say that after randomization, patient was with us approximately 6 months before we could offer the surgery. Staging laparoscopy was not done as per the study protocol in either the group, and so retrospectively there were many patients who had progressive disease of NACRT, and these patients may have mets at the time of induction that may be have missed, and after starting NACRT these will manifest, and then it will be labeled as a progressive disease. So the median survival, disease survival, they showed advantage in the NACRT group, but we did not reach the significance level. Obviously, the third part of this study is ongoing, and Dr. Himanshu is carrying forward this study, and we may be able to show a fresh light on this thing. The secondary endpoints favored NACRT. The completion of multimodality therapy, POPF, RGO resection, LBI, PNI, pathological lymph node involvement, these are all in favor, but statistically not significant. Logistic, multiple visit, prolonged treatment, financial constraint, hurdles of developing countries deliver multimodality therapy, and we need a large multicenter trial to confirm or review the finding of this study. And with that, I mean, there was one drawback which we realized, that had we used SEMS instead of plastic stent, only thing was the cost was prohibitive for us. The SEMS was costing around, at that time was around 30 or 40,000. Simple plastic stent cost around 2,000. So I mean, had we used the SEMS, then this delay in therapy would have been mitigated. So I mean, again, carry forward, we are working on these drawbacks, and that's all. Thank you very much.